It's my privilege at this point to introduce Dr. Stephen Pautler, right? What did I do wrong?
I'll answer Dan.
Dr. P, I said I was going to call him. Dr. Pautler attended the University of Waterloo and completed an honors in cooperative chemistry degree, and then graduated from University of Calgary Medical School in 1995. Subsequently completed his urology residency at the University of Western Ontario, right here in London. He became a fellow of the Royal College of Physicians and Surgeons of Canada in 2000, and has spent clinical and basic science research in minimally invasive interventions for urologic cancers before he joined the staff at St. Joseph's Hospital here in London as an assistant professor with the Department of Surgery. Dr. Pautler was cross-appointed to the urologic Oops, I missed something here, sorry. Department of Oncology. He was cross-appointed to the Department of Oncology and has co-authored more than 90 peer-reviewed articles. So we're in very good hands tonight with Dr. Pautler. He's in the Southwest Regional Surgical Oncology Lead for Cancer Care Ontario, as well as the co-director of the Endourology Fellowship Program, and he participates in the Society of Urologic Oncology Fellowship Program at Western. So thank you for joining us tonight. Dr. Pautler is going to speak about Kidney Cancer 101, management of early stage kidney cancer. I'm going to try and find you your... That's you.
There we are. Yay.
Yay. Oh,
Select the second option.
enable. Joys of IT.
Yay.
Thank you.
Thank you. Yeah, thanks, Wally. That was great. It's my pleasure and privilege to be here to speak to a group of friends, and I see so many familiar faces in the crowd. So I've been tasked with talking about early stage kidney cancer, and talking early stage kidney cancer, giving a little background of how we diagnose it, how we go ahead and treat it. So I'll try to run through this stuff and make sense about kidney cancer and what we're talking about. So I'll talk about localized kidney cancer, the workup, and then treatment. What is localized kidney cancer? Well, it is defined really as a mass in a person's kidney that has cancerous cells, most of which we believe start from a little area called the proximal tubule of the kidney. So the kidney is a filtering organ, and it's one of our ways of detoxifying our bodies. So kidneys are exposed to toxins every day, all day, 24/7. And unfortunately, these cells can be predisposed to becoming malignant. It takes a number of issues or problems with the cell for it to turn from good cell to bad cell. Now, some people unfortunately are predisposed to this with family history, and you heard Devin's story about genetic kidney cancer, which has greatly increased our understanding of kidney cancer and has actually dramatically changed this field. Kidney cancer has had more development than all other cancers in the last decade because of these discoveries. In my training at the National Cancer Institute in the U.S., my mentor there is a world leader in genetic kidney cancer, and really I think he should be shortlisted for a Nobel Prize, but I have to state a timeline, so I'll keep going, get off my soapbox there. What is the scope of the problem? What are we dealing with? Well, we're dealing with approximately 5,100 cases per year. This was the 2011 data. We do have about 1,600 patients die per year from kidney cancer. So this is a large burden in the Canadian healthcare system. Yes, it's not as frequently encountered as breast cancer or prostate cancer, but this is a very deadly cancer. Here's the statistics. When you look going down the line of all cancers, you can see prostate up there, lung, breast, colorectal, non-Hodgkin's lymphoma, bladder, thyroid, melanoma, then kidney. So this is a disease that healthcare, consumes healthcare dollars that we have to pay attention to. And it is something that I'm dedicating a large part of my career towards understanding this disease. Here's another way of looking at it. What's the probability of developing or dying from all the variety of cancers? And you can see 1.1% probability, lifetime probability of developing kidney cancer. So that, when all cancers in females, 40%, kidney cancer is 1% lifetime risk. So this is an important disease, and I've just thrown that's the female stats up there. There's another slide for males, which is similar. It's actually slightly higher in men. This cancer is rising as well. So many cancers we're seeing a decline. Kidney cancer is different. And that's an important message, and we make that message to those who fund healthcare in Canada, to our provincial governments, saying, look, this disease is one we're actually not ahead of. Now, we have certainly got much further along with very good treatments, but there is a prevention piece here which we do not understand. So, you've already heard from Devin. There's very few signs and symptoms in most individuals. Some individuals do come in with blood in their urine or pain in their kidney region, their flank. Sometimes it's incidentally found when they're being examined by their doctor and a mass is felt. But many people, we don't have symptoms that bring them to our attention. There can be complications if it's advanced kidney cancer. So it can be in the bones, in the lungs, can cause weight loss, fatigue, or other problems for a patient overall in their physical status. And then the family history can really be a clue. What do we do? How do we work up kidney cancer? Well, again, fewer patients are being diagnosed based on coming in with these symptoms. Now, I train surgeons from all around the world, and I've trained a couple surgeons in Mexico. The majority of patients in Mexico present with the classic triad of symptoms. But increasingly, they're finding earlier and earlier kidney cancers incidentally. And I'll touch on that in a few minutes. As I've said, the initial diagnostic test most commonly used is an ultrasound. But ultrasound's not sufficient enough to fully comprehend what's going on. So it's our clue. It says, oh, there's a mass or there's a lesion in a kidney. But for those of you in the audience, you can see the left-hand panel. That's an ultrasound. How many of you are comfortable interpreting that?
Looks like a baby.
It looks like a baby. That's right, twins. And unfortunately, this is a twin you don't want to have right here. This is a mass in the lower portion of the left kidney. Now, this is a CAT scan, which gives us much more information. So CAT scans or MRIs, we use them many times interchangeably, will give us more information. And it gives us the extent of the mass, it gives us information about other organs. In some instances, we go ahead and biopsy these masses. That's not always needed, and sometimes we don't actually want to biopsy a mass because it may change what we do clinically. And then if there is a family history, there is genetic testing available to look at some of the common genes, so VHL gene being one of them. But there are other clues that we look for before going to genetic testing. Genetic testing right now in Canada is actually a real mixed bag. Through the Kidney Cancer Research Network of Canada, we're trying to put forward a platform for comprehensive genetic testing in Canada. And I chair the genetic initiative for KCRNC. I'll say it wrong. And so that's one of our missions, is to improve genetic testing in Canada. Staging workup. Well, what does staging mean? We're looking for spread of the cancer. We want to understand the extent of this disease for the patient, and that helps guide our therapies and helps guide us with what the person wants to know. What's my prognosis? How long do I have, doc? So we do a CAT scan looking at the extent we do chest x-ray or a CAT scan of the chest, we do blood work, and then we do markers looking for spread to bone, calcium and alkaline phosphatase. We'll also do a bone scan if necessary. So this was a patient of mine who was a lovely 47-year-old woman who came in with a very, very large kidney tumor, and she had spread to her lungs, and she passed away about 4 years ago. She was a dear friend of a surgical colleague of mine, and it was a real tragedy. In her circumstance, we tried everything we could at the time that we had available, and the good news piece is she was a very strong advocate for kidney cancer, and she worked in healthcare. So some of the drugs approved now for use, she had a small part to play in getting these approved. When we're staging kidney cancer, stage is looking for this extent of disease. This is from the New England Journal of Medicine, is a fancy diagram showing the small tumor and then the stages. The more advanced the stage, the poorer the prognosis, the more aggressive the cancer. Here's another way of looking at this. I found this on the web from Mount Elizabeth Hospital in Singapore, and I thought it was a beautiful diagram showing the different stages of the tumor in kidney cancer, looking at the extent and size of the tumor and how far it extends within the region of the kidney. How do we treat localized kidney cancer? Well, we treat localized kidney cancer based on patient factors and tumor factors. That's how we look at it as physicians. We look at the overall health of a person. We look at their baseline kidney function. We look at the tumor size and location. The goal is, in localized disease, so it hasn't escaped yet, we want to remove all the cancer, but minimize our harm to the patient. So, as surgeons, we always harm people. For those of you who've been through surgery, you know that. And we've had those discussions personally. But the goal is really to put you through as little as we can with the maximal bang for the buck. Get this out. So, what's the history of localized kidney cancer? Well, the first ever surgical kidney removal was done in 1968 in Montreal. Sir William Higston. Unfortunately, the patient passed away. And this is rudimentary. This is in the days when there was barely any anesthesia. They didn't wear gloves in surgery, etc. A year later, Gustav Simon in Heidelberg, Germany, did a successful kidney removal. And only in hindsight did Higston say, well, I tried that, but my patient died. So Higston did a lot of things. I think he was even mayor of Montreal, so he had his hands in many things. We won't talk about Rob Ford. Around 1900, there were some improvements in kidney cancer. So people started recognizing the classic triad. They had the concept that kidney cancer actually came from the little gland on top of the kidney called the adrenal gland, which was incorrect. But they started to develop safe surgical techniques. The lower image is St. Joseph's Hospital, circa 1900. And that's how it looked then. It looks completely different now. With surgical improvements, there were improvements in detecting the cancers earlier. Thus, patients were not coming in as late a stage. They were able to undergo surgery and successfully be cured. One of the major contributions in this field was another Canadian, Dr. Robson at University of Toronto, who popularized what's called radical nephrectomy. And in a radical nephrectomy, you're removing the whole kidney, all of the surrounding fat, and in his classic description, you took out the adrenal gland as well. Now, there have been some modifications since the 60s when he first proposed this, but for many kidney tumors, this is still the most appropriate treatment. So, in localized kidney cancer, the only way to cure kidney cancer is actually surgery. Newer options are becoming available, and with that, part of it is minimally invasive surgery. So again, minimizing harm to patient, maximizing benefit. And the concept, the terminology you'll hear thrown around is nephron sparing surgery, if possible. So that's when we take out the portion of the kidney which has the tumor, leaving or rebuilding the remaining kidney. Again, Devin alluded to partial nephrectomy as her treatment. In genetic kidney cancers, most we treat with nephron sparing approaches. Some others we can't. The tumor's just simply too large, we have to take the whole kidney. And minimally invasive approaches are widely accepted. When I trained, it was heresy to propose to go in with small incisions and do the operation. We've proven that is completely wrong. It's not heresy. It is actually preferred because people heal faster, they return to normal quality of life faster, if possible. Now there are some tumors, again, that we can't approach using small incisions. We have to go through the big incision, and that's simply because of the extent of the disease. So a radical nephrectomy, we remove the entire kidney with the mass, as I alluded to. So again, open surgery or the keyhole surgery. And there are risks, as with any surgery. Bleeding, infections, blood clots, injuring surrounding structures. Kidney failure is a real risk in some individuals when we're removing a kidney. And if you only have one kidney, that's obviously a very pertinent circumstance. Partial nephrectomy, that's where we remove the portion with the tumor and rebuild the kidney. This is actually a more complex operation. The actual cancer control is equivalent to taking the whole kidney. Initially, when this was done, there were concerns that while you're leaving part of a kidney that had cancer, you're going to lead to more cancers forming. And outside of genetic kidney cancer, that has not proven to be the case. There are some increased risks. The risk of bleeding and urine leaking from the reconstructed kidney is greater. So we have to balance greater risk with the benefit of maintaining kidney function over a long term. This also, the leader in this field has passed away now, was at the Cleveland Clinic. He was another Canadian, Dr. Andrew Novick. Active surveillance. So there are some small kidney cancers that we will watch. This is a groundbreaking study that was spearheaded out of Toronto with Dr. Michael Jewett, who's a fellow member of KCC, been on the board, a founding member of Kidney Cancer Research Network. A group of us got together and we followed elderly and infirm patients, or patients who actually declined having surgery, who had small biopsy-proven kidney cancers. And we actually showed that they grow very slowly and they rarely actually metastasize when they're small. So it is safe in some individuals to follow them. Now some people, that's a short-term solution. Some people, if they have major heart problems, they come in and see me, they're in a wheelchair, 4 heart attacks, still smoking with oxygen. It's probably the best option for that individual because taking them to surgery will be the end of them. So you have to put it into context. This is not right for everyone. Why did we do this? Well, we learned that there were very good outcomes from localized kidney cancer resection. We also learned from the genetic kidney cancer group because, as again Devin alluded to, there are tumors that grow slowly in genetic kidney cancer, and we figured that actually in sporadic cancer, which is cancer that happens to Joe or Jane average, who don't have predisposition, also grow slowly for most cases. It is reasonable to offer a period of observation in selected people. The risk of it spreading is low, it's not zero, and the risk of death from kidney cancer in our group was low. The last thing I'll touch on is what do we do after we've done surgery? We shake your hand and say goodbye, Betty? No. What we do is we set you up on a follow-up program. And in Canada, we actually have guidelines that a group of professionals who are experts in the field got together, looked at all the evidence, and we follow these guidelines. And that gives us some ability to track kidney cancer for those unfortunate cases when it does show up again, so that then Dr. Potvin can see the patient and move on to the next phase of the journey. So with that, I'll end. I was told not to put any gory videos or pictures in here, so I didn't, but I do have some that maybe later in question and answer we can show if people are interested. So thank you.